Today, I talked about the program we are doing in the Philippines, that's something we've been doing since 2008. It's a community-based breast cancer control program we call Ating Dibdibin, or in English, Take Your Breast Care to Heart, or Take Your Breast Health Issues Seriously. We don't have a national cancer screening program yet in place. And so this is our bit, helping government push this forward. We partner with cities to institutionalize this breast cancer control program. We partner with cities because the mayors directly call the shots in the city health office, so it's easier to deal with them. They're the biggest, easiest champion for the program. And we don't partner with a city unless they agree to make the program a local law or an ordinance, because that way the program stays permanent no matter who the mayor is, and there is an assured funding stream somehow for the program. So we basically make sure that all the breast cancer patients are serviced through the whole continuum of care, from prevention all the way to treatment, survivorship and supportive care, palliative care, the whole shebang, the whole service delivery, and of course putting in place patient navigation. So some of our cities have patient navigators for each village. It sounds so simple to people from rich countries, but in our country, there is no patient navigator for cancer in the community. So this is the first of its kind. We have navigators in hospital settings, public and private, but in the community setting, there's really none. We discovered that patient navigation is really one of the secret ingredients to making any program fly regarding cancer and patient compliance. And so recently, we also decided to digitize and build a digital infrastructure for the program. As you know, if you can't measure it, you'll never really know where you're at. You have no way of improving. You have no way of knowing the gaps in care, instantaneously. It was something we've always wanted to introduce a long time ago, but it was so hard for local government to embrace the concept. It seemed like a lot of work. It's tiresome. So everything had been paper-based. But since the pandemic, everyone got used to digital stuff, QR codes for vaccination, entering a building. The buy-in was much easier this time. And what I'm proud to say is that patient navigators, who are usually community health workers, some of them are not college graduates, are the ones really driving the building of this data infrastructure. They're the ones putting all the inputs. So in this platform we call the Circle of Life, it's web-based. We had to study what was best. We couldn't do an app. It was too sophisticated for the simple smartphones of people in the community. Couldn't be Google Sheets or security problems, so it's now a web-based app. It's a simple electronic medical record of sorts, but doctors too can put their notes and record and document every patient visit. Lab results can be uploaded as well. You can upload photos. We also document the financial journey of the patient, so you know where they're getting their funding, which the navigator helps them with, and who is taking longest, so you know the gaps in care. And also those using the platforms are doctors, the IT team of the city partner, the city health office who is on top of it, and also the hospital personnel. So we assure that there's data privacy because very few have access to everything. Navigators are very limited in their access. It's usually certain officials only in the city health office who have access to everything in the dashboards. But it's been wonderful. For instance, I think the platform is giving more gravitas or giving more weight to the asks of the people in the city. So for instance, we are wondering why it took so long for anyone with a suspicious lump to get an ultrasound. And we found out because there's only one ultrasound in the hospital for all diseases. And when you talk to the hospital personnel, let's say the nurses, they say, oh, that's been there. It's been a problem, nothing new to us. We complain about it. So it's something they complain and complain. I guess no one pays attention. But now they can go to the mayor and say, we need our old ultrasound dedicated to breast cancer because we're depriving 150 people who are waiting. So their asks can be very specific. It's data-based, and so it's easier also for the mayor or whoever runs the city to allocate resources when they really see the gap in care and the consequences of this gap. Oh, when we partner with the city, we can't really tell them what to do. We can just share what has worked with our other city partners. We can share templates, but in the end, they really call the shots. It's always according to their context, according to their capacity. And so we don't bring in a legal team. They have their own, local version of Congress. It's their legislators that pass the local law. It takes a while. In the beginning, we would partner with them, do training, do everything, and then the law is happening simultaneously. But this time, we don't begin until the law is in place because they might forget to pass that law if we're done with everything. Not that we ever divorce them. We're married to them forever, always trying to update them and keep their program relevant and responsive. But yeah, they do pass a law. It can take up to a year or more, but we do wait because that law is very important. It keeps the program going. It's permanent and sustainable. And some of our partners even put patient navigation on a separate local ordinance. So it's really binding. Well, we've had studies done, whether focus group discussions, some are quantitative or qualitative, but just offhand, the gains of the program are there's less fear to go to the community health center for a checkup, which also means there's more confidence in the city that they will be helped financially. Because the fear or the delays in care boils down to two. For me, it's the myth that cancer is a death sentence, and secondly, it's financial catastrophe. There's no one's there to help them. So if you eliminate those barriers, then they go for a checkup. These women, a lot of them have awareness, but they're just very smart about their resources. They know they don't have a lot, and they have to start setting aside for the family if they think there's no one who can really help them through their cancer journey. Cities who partner with us, people are doing checkups, they're doing breast self-exams religiously, they're catching their cancers at an earlier stage, and out-of-pocket expenses is very minimal, sometimes next to zero for cities that we've partnered with. So other women who live in other cities will not be getting the same advantage. Our foundation, the ICanServe Foundation, is mostly made up of breast cancer survivors. I think, again, when you say you put the patient voice in the center, it's not just about their care, but also they can be partners in policy. They can have a table in decision making, in governance, when it comes to health-related programs. And still, I find that a lot of patient participation is still a token. I think it should be taken seriously, and we're not just consulted, but really given a vote on the table. And so we proved this when we passed the cancer law. The majority of those who lobbied for it were cancer survivors, including their carers, their families, their relatives. Even though we passed that law, when we had the meeting for the implementing rules and regulations, the list of people, they were all doctors. When I saw the list, I'm like, after the law, beautifully crafted, where are the cancer survivors in this meeting? And I had to insert myself. So we're always trying to do that, and we shouldn't have to do that. All this fuss is about us and for us. Partner with patient leaders. They have the near perfect empathy for the people you need to serve. And if for patient groups or just NGOs, you don't need to wait for national government to move. They are saddled with other problems. They can also be slow. Yes, they're very bulky. It takes too long for them to get in front of the problem. So do what you can, whenever you can. And always partnerships is key. We can never do it alone. We have to partner with so many groups, whether social civic organizations like Rotary, Seroptimus, Zonta, schools, churches, and of course, national government, other hospitals. It works that way. Even other patient groups. Down south in the Philippines, we got a local law passed for the Ating Dibdibin program with the help of a local group that helped us court this city for 10 years. So it really takes a village, that cliche. I also learned that patients should realize that they have superpowers. And it's not just peer-to-peer counseling. They can go beyond that. They can actually affect, and impact changes nationally. And I think a lot of revolutionary change doesn't happen up but down among collectives, NGOs, smaller groups. We try to think out of the box, out of desperation. In our case, we're losing too many friends, people who could have been saved but didn't know they could or couldn't afford. And so that's why I think we lobby harder and have a more sense of urgency. But we do acknowledge that we need to partner with experts. We are not the experts, but the patient experience is our expertise, which should not be neglected.